Orienting the patient to brief cognitive behavioral therapy. Orientation for brief CBT also involves a discussion of the focus and time-limited nature of therapy plus the therapist's rationale for selecting brief CBT to treat a particular problem. As noted in Module 1, this rationale includes the strong research basis of brief CBT and the fact that it is an empirically supported treatment. Many patients have little, if any, exposure to psychotherapy other than examples in the popular press. Providing patients with an understanding of the therapeutic process allows patients to be more active and aware of the role and the progression of therapy. Knowledge of the process of brief CBT enhances collaborative nature of therapy. When discussing the rationale for CBT and describing the process of therapy should occur in the first session. However, it is useful to revisit the model throughout treatment to expand upon the rationale for particular skills. The explanation of the model can be tailored to the patient's presenting problem, and the examples that are used to explain each component can be drawn from those generated in discussion of problems. For patients who think in concrete terms, it might be necessary to provide many examples and focus initially on behaviors rather than on cognitions. How? Introducing the cognitive model. The cognitive model is a theoretical paradigm for explaining how thoughts, feelings, and behaviors are associated. Most individuals believe that situations give rise to their emotions. The cognitive model challenges the subjective experience and suggests instead that it is the thoughts we have about situations that give rise to emotions. Individuals who are depressed or anxious tend to display patterns of dysfunctional or inaccurate thinking. In the cognitive elements of CBT, the therapist trains the patient in specific skills that help the patient learn to improve his or her mood and change behavior by modifying the way he or she thinks about situations. The behavioral aspect of cognitive behavioral therapy addresses how behaviors influence mood. The therapist works with the patient to increase behaviors to improve mood and reduce behaviors associated with negative mood. As depicted in the figure below, changing behaviors can change feelings as well as thoughts. The associations among behaviors, thoughts, and feeling in CBT are captured by social learning theory, which suggests that the likelihood of a behavior is determined by its consequences. For example, social learning theory implies that a positive behavior such as exercise will occur more frequently if a patient experiences pleasure and a sense of satisfaction after completing physical activity. Avoidance and escape are particularly learned behavioral patterns targeted in cognitive behavioral therapy. For example, not going to class because someone fears large crowds is an avoidance behavior. If someone leaves class because of anxiety over a large crowd, it is an escape behavior. Initial session. Prepare for the initial session. You are encouraged to thoroughly review all intake information. You need to intake information to form an initial conceptualization and formulation of a therapeutic plan. Using the patient's presenting problems, symptoms, current level of functioning, and history helps in developing the therapeutic plan. From the intake information, it is also imperative that you assess the patient's suicidality. This can be done by asking about the patient's suicidal intention, intent, or plan and determining his or her level of hopelessness as well as the reasons for hopelessness. If the patient's suicidality seems high, then crisis intervention is above all other therapeutic considerations. In the case of an acutely suicidal patient, you are encouraged to seek supervision or consultation and follow approved clinic procedures for managing a suicidal patient. Patient expectations for treatment. You should inquire about what the patient knows about how therapy is conducted. Orienting your patient to therapy includes describing the cognitive behavioral model and answering any questions he or she might have about the progression of therapy. Using the patient's examples to help explain the cognitive behavioral model will assist him or her in being able to see how the model can work and how it has worked for other patients with problems similar to his or hers. Often patients think therapy is a place where they will come and be lectured and told what to do, or a place to vent without a focus on behavior change. It is essential in brief CBT that the patient understands that therapy is a partnership between the therapist and the patient, in which they work together so that the patient can better understand feelings and solve problems. For brief cognitive behavioral therapy, patients typically attend weekly individual sessions for 4 to 8 weeks. However, the amount of time in therapy and the number of days a week can be reassessed periodically and adjusted to meet the needs of the patient. Discussing symptoms and diagnostic issues with the patient. Most patients want to know how they have been diagnosed. Explain the disorder in terms of cognitive and behavioral symptoms to clarify how CBT will directly address their problems. Giving patients descriptions of common symptoms of their disorder can also be helpful. There are cognitive and behavioral aspects of feeling depressed. Cognitive characteristics of depression include having negative thoughts about yourself, such as "I'm no good" or "things are not going to get better." Behavioral characteristics are ways your body tells you you are depressed, such as changes in your appetite or sleep patterns. Feedback. The collaborative piece of cognitive behavioral therapy involves asking a patient for feedback on the session. For example, "What did you think about our session today? Did we leave out anything you think is important to discuss?" And how he or she feels about the cognitive behavioral model. Do you feel you have at least a basic understanding of the model, or should we be sure to review it in detail again next week at the end of the first and subsequent sessions? Encouraging the patient to offer feedback strengthens the rapport and trust within the therapeutic relationship and indicates to the patient that they are an active member of the therapeutic process. It shows that the therapist cares about what the patient thinks and feels and values his or her input. This is the session. Was there anything that bothered you about the session or anything that you like to change? Getting feedback from the patient shows how important it is to work as a team and also helps you work on sharpening your abilities in therapy. It also allows you to attend to and repair any real or perceived therapeutic fissures or needed treatment modifications in a timely way. Goal setting. What is goal setting and why is it important to set goals in therapy? Goal setting is the process of collaboratively identifying specific therapeutic outcomes for treatment. Goals must be observable, measurable, and achievable and relate to cognitive or behavioral changes relevant to the patient's presenting problem. Goals are tied to specific skills to be addressed in treatment. Goals increase the continuity of the sessions, allow for directed, focused treatment, and enable the patient and therapist to assess the progress of therapy and identify change in an objective manner. Tips for goal setting provide rationale for setting goals. This helps the patient understand the direction of treatment and how he or she will be involved in the process. Example, if you can identify what you want to change about your situation, we can then take steps to correct the problem. Elicit desired outcomes. This involves the therapist assisting the patient in defining goals and specifying reasons for coming to treatment. Example, list a few things you would like to get out of therapy. Be specific about what the goal is. Determine each goal, what the goal is attempting to target, and what the patient's role is in reference to the goal. Guide the patient towards goals that require change from him or her versus others. Example, you said that you want your wife to listen to you. Since we can't really make someone do what we want, what could you do to help you feel heard or cope with a situation when you don't feel heard? State goals in a positive light. This clarifies what the patient wants to do instead of highlighting what he or she doesn't want to do. Example, list some things that you want instead of things that you don't want. For example, instead of "I don't want to be depressed anymore," you could list "I want to enjoy my favorite hobbies again." Weigh advantages and disadvantages of a goal. This aids in understanding the costs and benefits of the patient's achieving the goal. It may be used to motivate an ambivalent patient or identify salient goals for a passive patient or a patient seeking to please the therapist. Example, what would be the benefits if you accomplish this goal? What might be some of the costs to you? Define behaviors related to goal. This instructs the patient what actions to perform in relation to the goals that have been set. Example, what would it look like if you were less depressed? If I saw you and you were feeling happy, what would I see? What do other people do when they are happy? What things do you think have changed in your life since you have been depressed? What did you used to do that you enjoyed? What did you used to do that you enjoyed that you don't do anymore? Identifying maladaptive thoughts and beliefs. What are maladaptive thoughts and beliefs and why they are important in brief cognitive behavioral therapy? The cognitive behavioral model as depicted below suggests that there are 3 layers of cognitive dysfunction exist in individuals struggling with social and/or psychological problems: automatic thoughts, intermediate beliefs, and core beliefs. An automatic thought in a brief stream of thought about ourselves and others. Automatic thoughts largely apply to specific situations and/or events and occur quickly throughout the day as we appraise ourselves, our environment, and our future. We are often unaware of these thoughts but are very familiar with the emotions that they create within us. Maladaptive automatic thoughts are distorted reflections of a situation which are often accepted as true. Automatic thoughts are the real-time manifestations of dysfunctional beliefs about ourselves, the world, and the future that are triggered by situations or exaggerated by psychiatric states such as anxiety or depression. Intermediate beliefs are attitudes or rules that a person follows in his or her life that typically apply across situations, not situation-specific as with automatic thoughts. Intermediate beliefs can often be stated as conditional rules. If X, then Y. For example, if I'm thin, then I'll be loved by others. Individuals create these assumptions by categorizing the information they receive from the world around them. These rules guide thoughts and subsequently influence behaviors. Dysfunctional core beliefs drive dysfunctional rules and automatic thoughts. For example, the belief I'm unlovable may be driving the conditional rule, if I'm thin, then I'll be loved by others, which may drive obsessive thinking about one's appearance, excessive exercise, or disordered eating habits. Core beliefs are often formed in childhood and solidified over time as a result of one's perceptions of experiences. Because individuals with psychological disorders tend to store information consistent with negative beliefs but ignore evidence that contradicts them, core beliefs tend to be rigid and pervasive. Because individuals with psychological disorders tend to store information consistent with negative beliefs but ignore evidence that contradicts them, core beliefs tend to be rigid and pervasive. Although automatic thoughts are often tied to a specific situational trigger, intermediate and core beliefs are more global and cut across domains. Beck suggests that individuals tend to have core beliefs that involve either interpersonal or achievement issues. Automatic thoughts in session. Be aware of patients' thoughts during sessions. Hot thoughts are automatic thoughts that occur in combination with a change in emotion or mood. Hot thoughts are particularly poignant or strong thoughts that are often associated with dysfunctional core beliefs and should be targeted in therapy. Hot thoughts and the accompanying situation and emotion are tracked on the first 3 columns of the thought record. To identify which automatic thoughts are hot, the therapist listens for verbal cues, such as the language used in the thought, and watches nonverbal cues, such as increased volume of speech or fidgeting. To identifying which automatic thoughts are hot, the therapist listens to verbal cues such as the language used in the thought and watches nonverbal cues such as increased volume of speech or fidgeting. Changes in facial expression, shifts in position, or hand movements can be helpful in determining whether a patient is experiencing an automatic hot thought. Listening to tone, pitch, volume, and the pace of a patient's speech is also beneficial. When you notice these actions, this is an opportune time to bring it to the patient's attention and assist him or her in identifying an automatic thought associated with the shift in emotions. In these instances, you are simply an observer of the behavior and make a note of your observation to the patient. You are speaking more loudly. What is going through your mind right now? The patient then provides an explanation of the behavior. Automatic thoughts between sessions. In brief cognitive behavioral therapy, a principal characteristic is the work the patient does outside of session. Because identifying automatic thoughts is a novel concept to many, practicing outside the session will facilitate movement and change in therapy. In fact, Burns and Nolan Hoxema found that patients who completed homework had significantly better treatment outcomes than those who did not. Practicing key skills between sessions allows session time to be used for new skill acquisition and troubleshooting. Initially, when a specific situation is brought up in session, always ask what is going through your mind at the moment. This helps the patient build awareness of his or her automatic thought both within and outside of session. Because of automatic thoughts may occur outside awareness, asking for a more detailed description of the situation is also helpful in pinpointing maladaptive thoughts. For example, you could take the patient back to when it happened using imagery. Where were you when this happened? What time of day was it? If the patient reverts to past tense, remind him or her to tell the story in present tense to help bring back the thoughts and feelings that occurred in this situation. With continued questioning, it is possible that there may be more than one automatic thought associated with a problematic situation. Elicit and record all automatic thoughts given for a particular situation. Core beliefs. Throughout therapy, hypothesize core beliefs that may be underlying dysfunctional behaviors and thoughts. These hypotheses aid development of the case conceptualization and treatment plan. A belief that is likely to be core will appear in several different areas of patient's life, for example, relationships, work, parenting. If time permits, in brief cognitive behavioral therapy, after we have collected enough evidence to support the alleged core belief present and discuss it with the patient. Challenging maladaptive thoughts and beliefs. What are the techniques for challenging maladaptive thought and why are these techniques important for brief cognitive behavioral therapy? Several techniques can be used to challenge dysfunctional thoughts or beliefs. Most are used in conjunction with a thought record. Challenging thoughts and beliefs in a collaborative Socratic way allows patients to use their own statements to encounter dysfunctional thinking. Generating counter-statements based on the data patients bring to session increases the believability of the thoughts or beliefs and thus the effectiveness of the counter-thoughts or beliefs. Socratic questioning is a therapist's stance for questioning maladaptive thoughts and beliefs. This process involves asking a series of open-ended, brief questions that guide the patient to discover his or her idiosyncratic thoughts, feelings, or behaviors associated with a particular situation. Socratic questioning is non-judgmental but is based on the therapist's insight that the original premise of a thought or belief may be untrue. Therefore, the questions are designed to expose the dysfunctional thought or belief so that it may be challenged. The dysfunctional thought record, DTR, is the staple of cognitive work in brief CBT. The first 3 columns are used for identifying troubling situations and the accompanying emotions and dysfunctional thoughts. These 3 columns are used in conjunction with Model 8 in that when the situation thought feeling triangle is unfolded, it forms the first 3 columns of a DTR. Once a hot thought and its accompanying emotion have been identified and rated, the hot thought is a question to generate evidence for and against it. Building evidence may be introduced in the following way. Example: we have identified a thought that is very powerful for you. You rated this thought as 90 out of 100 for sadness. Before spending a lot of time and energy on this thought, I want to know whether or not it is true. Often when people are depressed or anxious, they take thoughts like this at face value, without first asking whether it's true. Accepting thoughts like this as true would certainly lead to the symptoms you have been struggling with. If I thought I'm worthless and can't do anything right, I wouldn't want to get out of bed in the morning either. and I would probably feel pretty hopeless and sad. When we test a thought like this, we are going to generate evidence for and against the thought. It is as though the thought were on trial and you were a lawyer for the case. Remember, you have to be able to prove the evidence you are generating. So, now let's see how your thought stands up. What is behavioral activation and why is it important? Behavioral activation includes a set of procedures and techniques aimed at increasing patient activity and access to reinforcing situations that improve mood and functioning. Behavioral activation amounts to the B in cognitive behavioral therapy interventions. From this behavioral standpoint, depression, for example, contains a host of characteristics that function to maintain depressive effect and decrease chances of adaptive coping by increasing avoidance. The key here is that difficulty with mood often serves to increase avoidance of adapting coping, including pleasant events which help to alleviate and avoid depression. Reintroducing pleasant events can serve to improve mood in many different ways, reversing avoidance, increasing physical activity, increasing self-confidence, and increasing feelings of usefulness and purpose. Recent empirical evidence suggests that behavioral interventions improve mood symptoms but also reduce maladaptive thought patterns. Step 1. Provide patient with rationale for behavioral activation. It is important to educate the patient as to what behavioral activation is and how it can be useful for improving depression and anxiety. Let him or her know that when feeling a little down or having a bad day and not feeling well physically can make it more likely that he or she will stop doing many activities that used to be pleasurable. When this happens, the patient can get into the habit of avoiding pleasant activities that might actually help him or her feel better. It is also important for the patient to understand the connection between what he or she does and how he or she feels, both mentally and physically. You are encouraged to explain to the patient that increasing activity and or taking action even when we do not feel like it help one to feel better physically as well as decrease depression. Step number 2. Identifying behaviors, discussing activities. Identification of potential activities begins by exploring with the patient activities that would be most meaningful. Have a general discussion of types of things he or she would like to do but have not been able to do and activities he or she already does but would like to do more often within the context of values or goals that are important to him or her. You might want to ask if there is something that he or she needs to do that he or she has been unable to do or has been avoiding. Some patients may want to accomplish something rather than focus on doing something pleasant. Can you think of any activities or hobbies that you would like to do but have never done? Are there any things in your life that you would like to change? If so, what would you like to do about these issues that you have previously not done? Step number 3. Setting an action plan. Once the patient has identified a meaningful activity to focus on, help shape this work into a meaningful therapeutic goal. Action plans are one mechanism of creating meaningful behavioral goals for therapy. Action plans in their most basic form stipulate the specific goal to be obtained, defined in terms of observable and measurable characteristics and a time frame for monitoring progress. Example. Goal: to read at least 3 times per week, a minimum of 30 minutes per reading session. Time frame: patient will complete 3 reading sessions over the next week. Step number 4. Monitor progress in mood, mastery, and confidence. It is important to monitor the patient's mood and feelings of mastery and confidence. Outcomes such as improvement in mood, mastery, or confidence can be best identified through patient homework assignments that ask the patient to document the frequency and use of the behavioral activity and any corresponding emotions or feelings of mastery or confidence. On the basis of this monitoring of outcomes, evaluate the action plan and the patient's ability to work towards achieving goals. If problems arise, make changes accordingly, for example, breaking down goals into smaller steps, determining patient perceptions of importance, and changing goals accordingly. Monitoring shows the patient that you continue to believe in the importance of the technique or exercise and also serves to further motivate many patients by increasing the effectiveness of the intervention. Tips for managing barriers to doing activities. 1. Help the patient break down more difficult activities into smaller steps. Look for alternative behaviors to accomplish a goal prohibited by a chronic illness or other physical limitations. For example, a structural or mechanical engineer who was forced to retire because of physical limitation may feel that his or her life is no longer productive. Although the patient is physically unable to fulfill prior job duties, you can work with him or her to identify 64 meaningful activities related to the prior. In this case, the patient might benefit from volunteering at a university providing consultation or volunteering for a local school, youth, or church organization. 2. It is also helpful and supportive to look for ways that others can help. Family or other social networks that the patient has not yet fully engaged might exist, which might assist the patient in moving forward on goals. Pleasant activities are the best first step. Pleasant activities are doubly beneficial to the patient as they increase activity and feelings of pleasure. Activities designed to overcome avoidance or increase a sense of accomplishment should be entertained as the first goals only if highly important to the patient or apparently salient to the attainment of future goals.